DPC is my why. It's the only way that I would ever dream of providing primary care, here in the United States. It makes sense. The economic model makes sense. The relationships you have with patients make sense. The autonomy makes sense. It's literally the only way to provide primary care services here in the United States. I'm Allison Edwards. I'm a physician and I'm from Kansas City Direct Primary Care. And this is my DPC story.
Welcome to the podcast, Dr. Edwards.
Hi, thanks for having me.
Your journey has definitely taken you very far from Lawrence, Kansas, where you grew up. And so I wanted to start with something that was really, really impactful. Last year in Forbes magazine, you were quoted around Sesame's raising $24 million for their venture. But the quote that you said was, "The insurance system is so opaque and full of hoops to jump through. It's no different on the doctor side than on the patient side. We are equally frustrated with how poor of an experience working with insurance is." So given that DPC is your why, as you explained in your opening statement, this is so appropriate. And so you saying how the doctors as well as the patients are experiencing frustration really highlights the why of this movement. So I want to ask, can you give us a little bit of a picture of your history in medicine and beyond so we can understand where you came from and how you came to this quote?
Absolutely. And thank you for having me. This is absolute joy. I'm so excited to be here. So I went into medicine because I wanted to help people. I think that a lot of people, especially those who are drawn to primary care, are drawn into medicine probably for that reason. And I'd actually grown up, like you mentioned, in Lawrence, Kansas. It's a relatively small college town in the northeast part of Kansas. And I had always worked for small businesses. Like I'd worked for a hardware store and ice cream shop, and I was a server and I was a barista and everything. And I like to share this story. One day I was 16, and my boss, who was not the kindest person, asked me. I was a server at the time. He goes, "Who do you work for?" And I was 16, and I'm talking to my boss, so I was like, "Obviously, you. I work for you." And he laughed and he said, "No, you work for the person who signs your paycheck." And what he meant by that was that if you, at least when I was 16 in Kansas, if you were a server, your paycheck was zero. Your literal paycheck was nothing because it kind of got all eaten up by taxes and whatnot. And his point was that the person I worked for was my customer at the table, the one who was giving me the tip, the one who I was paying attention to make sure they had a good experience and a great meal. That was the person who I worked for because they were the ones who were ultimately paying me. And so that sort of ethos and mentality and small business mindset and relationship based, like small personal touch was, what I grew up with culturally. So that when I finally gotten into residency and was working for a large healthcare system, it was the first time I'd actually worked for any sort of a corporation and a bureaucracy, not to mention the fact that it was, we're steeped in insurance reimbursements and all of those constraints. It really hit home that if I was going to work for somebody in healthcare, I didn't want to work for the large corporation, and I certainly didn't want to work for the insurance companies. I wanted to work for my patient. And so DPC is the way that you achieve that, right? Like they're the ones, your patients are the ones that sign your paycheck, so to speak. They're the ones that pay you. And so they're the ones that matter. And so I think, that's why that's my history. Like that's where I come from. And that's how I arrived at direct primary care.
That's incredible. I was talking with a person today, a medical student, he's in 4th year, and he was talking about how could he go through residency now knowing DPC exists, and how can he go through the everyday clinics, especially knowing that he's going to enter into fee-for-service. And I told him, similar to how you said, this is your history. I said, and I challenged him about your mindset, that your mindset in residency can be very jaded, but like Lauren Hughes, who is you're also your neighbor at Bloom Pediatrics and Lactation, she pointed out how during residency, when she knew that she was going to do DPC, she thought about things differently. She collected attendings' phone numbers. She operated differently so that she was ready to open DPC and already had that network and plan and, the business plan and everything prepared. So I really love that.
Absolutely. Yeah. It's all in your mindset.
Now, something that was very interesting that I did not know about is that before opening DPC, you were a research intern for ABC, and you were an intern specifically for the news medical unit. And so I wanted to ask, because, DPC is a grassroots, so to speak, movement, but at the same time, it's growing like wildfire.
Right.
And when we're working with groups, employers, et cetera, the community around us, because our culture is so ingrained in fee-for-service medicine, they want to know data. And so I want to ask, when you are working as a DPC physician, when you understand DPC from your perspective, and you've also been involved in, doing research, I want to ask, what type of research would you like to see done in DPC to help push this movement forward?
This is just such a fun question to think about. I have to tip my cap to a couple things. So number one, anytime you measure something, you change it, right? So that's part of the paradox of like gathering data and trying to make sense of things, is that inevitably when you start to mess with things, you mess with things. But I think that what I would like to see, and this is a pipe dream, and I don't necessarily have the path laid out for it as to how we get here, but what I would like to see is sort of that longitudinal data that very directly ties DPC membership to better health outcomes, right? Decreased morbidity, decreased mortality, because those are obviously those patient-centered outcomes that we actually care about. And then maybe on like a less grandiose scale, like, do our patients like us? Do our patients have a good experience? Do our patients feel like they're listened to? Do our patients feel like they can rely on us when they're going through something fairly significant? I think that the patient-centered primary care measurement tool that is out of the Larry Green Center it's a phenomenal tool. And for those DPC doctors who are out there listening, it's a free resource. I believe it's 10 questions, maybe 11. And we have administered that to the patients in our practice annually. And it's validated across cultures. It's available in a couple different languages, but it measures the things that make sense in primary care. And so I think they're on the right track there. Because ultimately, from a research perspective, and going back to, you mentioned my time with ABC News, when you're trying to sort of tell a story, if you will, when you're trying to change somebody's mind, someone's behavior, someone's culture, you alluded to, our society's stuck in fee for service. Everybody thinks health insurance is health care, right? So when you think globally about, how do we change a culture, nobody gets jazzed about data and statistics, and like, according to our statistical survey and this tool that we have, people get jazzed about anecdotes. And so I think that that's the other side of it, is like, how do we continue to collect stories, which is what you do here? How do we continue to have that narrative of like, this is how impactful a good direct primary care, a good primary care relationship can be? But then when somebody wants to get all wonky about it, so if you're talking to an employer or a politician, or maybe just an overly eager potential patient, you can, flip to the other side and say, hey, look, we've got survey data that, our relationships are more meaningful. Our NPS scores are better than, almost any other industry, So I think there's kind of two sides to that, data and research thing, and they're equally important.
And on that note, because you have been in practice for so many years at Kansas City DPC, you founded it, you opened it, you made it thrive. I want to ask, because we have the upcoming DPC Summit in Kansas City, and it's going to have 3 different tracks: the 101, the 201, and the 301. And so that's really allowing people to go to content that is pertinent to people starting out in DPC, people who are in those first few years, and the people who are looking to, potentially add more services or get into specific types of offerings more in depth. So I want to ask, in your practice, could you highlight your 101, 201, and 301 tips for those people who might be listening to this podcast today and 5 years from now?
I think anybody who started a DPC practice could like just go on and on about all the mistakes you've made. I think my one-on-one advice is kind of like a pep talk, right? You are a doctor, you're smart, you can learn anything. And as long as you apply yourself, like, it's like, hunker down, like, network, get out there, learn, get mentors, learn from some of those, flashy business books and things like that. Like, develop your marketing strategy, all that stuff. Like, it's out there. People are willing to help you. There are small business development centers that are federally funded. There's no cost to you. You don't have to pay for a business coach, and you can learn a lot. But you do have to dive in, and you have to dive in head first, and you gotta be able to swim. You can't just kind of wait and put your toes in and just expect to be good at DPC. It's when done right, a DPC practice is a thriving small business. And so you really have to have that mindset that you are opening up a small business. So I think that's sort of my 101, like, rah, rah, go get them, you've got it. And then of course, as time goes on, like, when I give a lecture to the 4th year med students about direct primary care, there's this point on my growth. Like, I would actually pencil in on a weekly basis, I would pencil it. It's on this printed graph paper, like how many patients I had every Monday for the entirety of my business until I left for maternity leave last fall. And then priorities changed. I don't have time to pencil it on a piece of graph paper. But anyway, I show these fourth year students, there's this inflection point that I point to on the chart about 6 months into my venture where I was like, oh no, I'm a small business owner and this is working and we're growing and I'm going to have to figure out a lot of stuff to make these systems work. And so I think that's sort of the 201 advice I would give is like, when you're in 101 mindset, that's so important because if you can't, take flight, 201 doesn't matter.
Yeah.
But in 201, you also have to like set your boundaries, start thinking about like what practice can I sustain and what behaviors can I sustain and what expectations can I set for myself? What expectations should I set for my patients so that I can have a long and fulfilling career? And that needs to happen right after liftoff, right? Like you got to get your plane off the ground, you got your business off the ground, then immediately like this is working and that's a good thing. But it also has to work for the long run, right?
Yeah.
I think a lot of times in residency, your intern year, your attendings are like, don't spend an hour with your patient because they're gonna expect that when you're a third year. And it's like same thing in DPC, like really be clear about what you're gonna be able to do in the long run and not burn out because burnout is just, is an overextension of yourself, right? So think about that in your 201. My 301 is kind of thinking about like the longitudinal, like how do you create that adolescent business that can kind of run without your explicit involvement on a minute by minute, day by day, week by week basis? How do you get the processes in place to have robust staff and thinking about cultivating a great culture within your practice through the clinicians that you involve, whether that's MDs, PAs, and Ps. How do you build that? Do you have MAs? Do you have LPNs, nurses? What ancillary staff do you have to support you? And then also you really do, and I know that this is kind of a third rail, I guess, in DPC, but you have to think about benefits. And people actually do care about health insurance. And so like think about, are you going to provide, DPC coverage, maybe at another clinic or find some way to ethically provide it for your staff and then encourage them to do a health share industry? Are you going to encourage them to go on the exchange? Are you, how do you think about that? Because in today's climate with hiring, it's really, really tough to compete if you aren't thinking about those things. And then because it's fresh on my mind, should probably think about what to do if everybody in your clinic gets pregnant at the same time, because that's hard on a small business, especially if you want to provide for any sort of a parental leave. So things like that, like short-term disability, medical benefits and healthcare and stuff like that. So that's all important. Retirement, all that stuff. That's when you got your big boss pants on. You got to start thinking about these things.
Such great tips though. And especially, in this climate where we're seeing DPC grow exponentially, it's really wonderful to hear those words from someone who is so experienced so other people can think about what they would do if they had, everybody pregnant at the same time, or if they want to really provide some kind of healthcare coverage or 401k, et cetera, for their employees. Now, you mentioned this Larry Green tool, but when you talk about culture in your own practice, how did you specifically work on building culture, especially for those people who are like, I sort of get DPC, but they're not really necessarily all in as much as the founders of clinics are?
Oh my, I am not probably the right person to speak to this because I don't know if I've cracked the code. I think there are a lot of really, really great clinicians out there who have developed a great culture. And I have to tip my cap to my current business partner, Kylie Vanneman. She has done an amazing job with the growth of her clinic and developing a beautiful culture. But part of it is being intentional about it. And I see this in what she does and, saw glimmers of it in kind of what we were trying to develop. And I'm spoiler alert, we've merged with Health Suite 110 and Dr. Kylie Vanneman is now kind of my business colleague. So I'm going to sing her praises a little bit because I think her culture is beautiful. And that's partly why we've merged with them. But, there's an intentionality to it. They have a weekly meeting with the staff. There's 3 nurses, 4 physicians, and it's, phones off for an hour, lunch, on Tuesdays, everybody sits down and make sure that we're all on the same page. At the beginning of it, everybody practices a gratitude exercise, a centering exercise. That's important. we did this too at KCDBC, like having a fund where if a patient couldn't pay, we could personally, cover their costs or for their medicines or whatnot, and be intentional about being empathetic for our patients. And then, ultimately, there are some people who just are not good culture fits.
Mhm.
And when you become somebody who is in the position of hiring, to a certain extent, you kind of have to be okay with getting good at firing people. And that's hard. And there's a lot of different ways to think about that and whatnot. And having fired my share of people, I'm happy to grab a beer with anybody who wants to talk about it, about the things I've learned, how to do it well and how not to do it. And of course, there's also legal aspects to that I won't get into. But it's tough. I'm sorry, I don't have a great answer for that, but I would say it's work. It's a concerted effort.
And I think that that's a very fair answer, especially given your 101, 201, and 301, high level thoughts there, because your business is not on autopilot. Your culture is not on autopilot. So I think that's really, really a total fair answer. And I think that other people can really relate to that as they're trying to face that challenge and make strides in the cultures in their own practices.
Oh,
So
I have to say one more thing on that.
yeah.
I moderated a panel. I think it was in last year's AFP. I've lost track of time. COVID has really distorted my perception of time. Anyway, it was with Rob Robsborough and Amy Walsh on Opposite Coasts. And we talked about culture. We talked about this subject. It's like, well, how do you find great people? And Rob was like, well, I don't know. I've had my gal for 20 years. I just took her from my last clinic. And Amy was like, oh yeah, we've had our LPNs. We trained them up. We've kept them. We're a solid team. Da, 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 da. I'm like, guys, that's great for you, but there are dozens, if not like hundreds of people out there listening to this who hate you right now, because that is like, essentially what they were saying is, oh, I hit the jackpot. I found a great person and I'm stuck with them. So I think that the big lesson that I took from them in that comment on developing culture and building a, beautiful workplace is that if you find people who are great, keep them,
Mhm.
figure out how to make it work and keep them.
Yeah. I love that. And not necessarily delving into specific examples in your practice, but when you talk about when a person does not level up to the culture that you need them to, or that your patients need them to, how do you mentally and emotionally go through the process of firing someone or letting someone go? Because I know that that is a place of difficulty when it comes to being a business owner, because we're trained to be physicians, and even letting a patient go can be uncomfortable, but a
Mhm.
lot of the times there we have like actionable reasons when it comes to a staff member.
Right.
What words of advice do you have for people who are in that? Do I keep them on or do I not? How do I go about this? Because some people say, just rip the band-aid and this is business is money, and
Yeah.
you can't afford any more days of subpar care or subpar service. So I just wonder
Yeah.
on your thoughts there.
As any good clinician, I have to give a caveat. You should get a lawyer on your side to make sure,
Yeah.
because every state has different really specific laws regarding employment. So like, do not do not go into this process without consulting sound legal advice. But from just sort of a higher level perspective, if you do not feel bad about firing somebody, you need to check your pulse, right? Because like, you're taking away somebody's income. Like, we
Yeah.
identify in the US so much with our careers and where we work that it is a big, big, big deal to take that away from somebody. And so this is not to be taken lightly. That being said, you're not walking into the office one day guns blazing, right? And like, give me your keys and turn
Yeah.
off your laptop, get out of here, right? Like, to a certain extent, your point of like somebody mentioning like rip the bandit off, you can't tolerate it. Like, if there is somebody who is actually dangerous and a threat to your patients, or is a potential to cause harm, like, that is something that needs to be addressed immediately,
Mhm.
and that needs a quicker time course. But if it's somebody who is not actually, you're not worried about, perhaps patient harm or something like that. My ethos is one of like, you've got good people, like you hired them for a reason. Sit down and be very clear with them, because to be clear is, I think, a fantastic attribute of a leader. And to say clearly, like, I love this about you, and I need this for, from your performance in order for us to continue this relationship. Be explicit. This needs to be something that's tangible. It needs to be a benchmark. It needs to have a time frame. You're going to check in with them again in so much time. And I think a lot of employees Or, people listening might roll their eyes and say, oh, this is just a pathway so you can fire them. And that's not the case, right? You should be doing this with the intentionality of growing this person and developing this person and supporting them in becoming a great player on a DPC team, right?
Yeah.
That this is not punitive. It's for growth. And if you approach it in that way of, I'm not angry at this person, I want them to grow and I need this out of them. And they see it that way, and they receive that you are supporting them as a leader and as their boss. That has great potential. And there's a lot of work there. Alternatively, it can also be a great opening to have that really frank conversation where they're like, maybe these aren't the benchmarks that I derive meaning from in my job. And, maybe this isn't the right fit for me. And maybe, I should be looking at another career or another position. I think being honest and frank about expectations and again, without any punitive behavior behind it is really important.
Very sage comments with regards to employment of others, especially because we saw how many people really did suffer losing their jobs and losing their health insurance with this pandemic.
Yeah.
So yeah. When you talk about culture, I want to shift a little bit towards your impact on future primary care physicians and the fact that you are still involved in the residency in Colorado as well as in Kansas City. You have been writing for the American Academy of Family Physicians New Physicians blog, and the articles that you've written in there just really, really highlight the culture that you put forth in medicine. You were even on the main stage in 2019 at the National Conference for Residents and Medical Students, and you spoke about a particular resident you had been assigned to work with. And that, in the summary of that presentation, you were talking about how that resident was, if not fully burned out, crispy and on his way there. So when you're talking with other future family physicians, future DPC physicians, what do you, in addition to, that graph that you talked about, penciling in how many people you see on Mondays, what do you talk with them about in terms of potential as a physician?
I think it's really interesting because we live in this bubble, right? Where we're like, of course, DPC, and of course, everybody knows about it. And of course, this is the right answer. And it's so invigorating to tell students and residents about direct primary care when they haven't heard about it before, because man, you can just see their eyes, like they get like the 1,000-mile stare and like the gears start going in their head and they're just like, wait, what? Like you can wait, no one should, what? Like people would just pay what? And you could just see this. And so I think you already brought this up, but like just it's a matter of thinking about your mindset, right? Like, here's somebody at the beginning of their career, they can do anything.
Mm-hmm.
And I even talk to students too about how you can be a specialist. You don't have to be primary care to really understand and get behind the principles of a direct primary care relationship. You can think about things in just a simple, like, let's peel all the layers off the onion and just have a transparent price at which you can provide really high quality healthcare, right? Nobody's asking any physician to commoditize themselves down to the basement. That's not what we want. And that's not good for our profession, which ultimately is not good for patients if we're not able to repay our loans and you don't get sort of the smartest and most driven people to be actually providing healthcare services, right? But it doesn't have to be as expensive as it is. And so, I try and light that fire of like, you guys can think outside the box. Like you can make your career what you want. You can push back. And if we all as physicians start to become empowered to behave a little bit more entrepreneurially and a little bit more as advocates for our profession and ultimately for our patients, and push back against these huge mergers and like big corporate influences and big insurance pressures, if we all stop signing contracts with crazy stuff in it, the crazy stuff would disappear because there would be no physicians. And so I try just and empower, students to just think and push back.
In terms of, your involvement with these residency programs, do you do any clinical work with them as well? Or do you do remote sessions on just what you shared?
Yeah. So for the University of Colorado, I am a volunteer clinical professor for the residency program. And so I generally actually try and structure it as a conversation with it kind of an open question, how would you change healthcare? What would ideal healthcare be like for you? And it's really amazing to see where the residents take that conversation, because ultimately, obviously, it all can be solved by DPC. But yeah, that's how we kind of frame things with the University of Colorado. And here at the University of Kansas, here in Kansas City, it's more of a clinical relationship where at the clinic, we've brought in students in their in their third year clerkship and some kind of elective weeks in the first and second year, but mostly the third year clerkship. And then I also I'm on the board of trustees for the student run free clinic, which is also really fun because that really gets students thinking about like operationally, like how does a clinic
Yes.
run? Like how do we provide care and at what cost? And, the unit economics of actual provision of healthcare. So it's a wide variety of different ways. And I encourage anybody who's listening, medical schools are always looking for volunteer clinical preceptors. And it's a really, really rewarding thing to give back to students. And they also ask really good questions, which means that you have to be at the top of your game. So it keeps you really sharp. So I highly recommend staying involved or getting involved in your local med school or residency.
Yeah. And I think it also adds a layer of thinking about your business differently, because when you have people who are very, just like our patients sometimes, very new to the world of direct pay and direct pay models, they have very basic questions, and you can really, like you are every day, impacting the future DPC doctors. Hopefully, when you talk with the residents, you can really think about your business in those high level, like what would a basic question be about, my marketing, my workflows, et cetera. And so it really helps you also think about your own business and how it's run and how you can improve based on their questions. So I want to ask there, and you mentioned how you have recently merged KCDPC with Dr. Vanneman's clinic.
Yeah.
I want to ask, how do you even merge a clinic? Because that is definitely something that as we go into the future, like Dr. Doug Farrago has retired, he sold his practice, but definitely mergers are something that are bound to happen with physicians in the future of DPC. So how would you start explaining how to merge a clinic?
Who knows? And I feel like, the answer is always, if you've seen one DPC clinic, you've seen one. If you've seen one merger, you've seen one. I do want to back up just to say, because I know that it kind of, I'd said on some of the message boards and in some of the social media groups that like I'm selling the clinic, and it kind of raised flags. People like, oh my God, what are you doing? The reason I'm selling the clinic is because my passion in medicine is not necessarily in the provision of like one-on-one primary care every day.
Yeah.
I derive a lot of joy and pleasure from thinking about systems levels of care, healthcare provision, health policy. How do we as doctors like provide outstanding healthcare to our community, to our neighborhood, to our state, to our nation, right? Like that's what gets me jazzed. And so I really wanted to make sure that my patients were well cared for without, me getting in the way of their care, basically. It made for an easy transition because as I alluded to, everybody at my clinic got pregnant last year. We had two physicians, myself and my partner. My nurse also got pregnant. We were spaced about 8 weeks apart. Everybody was, delivering 8 weeks apart. And just our poor patients, the transitions and like training up new staff to cover for everybody, paying for my nurse's parental leave, trying to figure out how to work through my partner's parental leave. And then eventually he decided, he had a 45-minute commute each way. This was his second kid. His wife's in law school. He wanted to prioritize family. When my nurse came back from her parental leave, she wanted to prioritize family. So she decided, she was like, she left and went part-time. And so it was a really interesting position to be in where I'm, I think I was 3 weeks postpartum when my nurse told me she wasn't going to come back. And my partner had left and I had hired an NP to kind of cover things. And it was this crazy paradox where I have a highly successful clinic we were full, great location, generating revenue, growing by word of mouth, not really spending much on marketing. And I had lost, all like my culture. I'd lost my people for really, really joyful reasons, right? Like who can get upset about people having children and wanting to spend time with their family? And so essentially that was when I was like, I want to make sure that our patients are well cared for. And that's kind of where the conversation started with Dr. Vanneman about bringing our patients into the fold of their clinic. They had two physicians who still were not full. I am going to step away from day-to-day patient care. So I kind of transitioned my patients into their care. Obviously, we've had churn and drop off. It's fascinating with all the with all the pregnancies and like the changes of the last year. We have a ridiculously resilient patient population because they've stuck around through just an insane amount of chaos, and I bless them for that because it's amazing that they've stuck around. But when we changed locations, we moved about 8 miles south. Like that was, some people were like, whoa, like you left my neighborhood, I'm done, which was interesting. Like I think we all as doctors like to think that it's us, the person that
Yeah.
people are sticking around for. But I've also found that it is the address that people stick around for. So just, it's interesting. So
Very
I'm happy if
interesting.
anybody's listening and wants to hear more. I'm an open book, but it's essentially, as far as like the price and like how we've negotiated all of that, we did it very differently than I understand Dr. Frago did, in that I'm basically sticking around to help transition patients.
Mhm.
And we're going to figure out kind of how many people stick around and for how long, and kind of come up with sort of the financials behind it in the end. So and Kylie and I have a great working relationship, so that works for us. And so that's kind of how we're going to take things from here on out.
Gotcha. And going a little bit further into that,
Yeah.
when there is a merger happening and potentially there's different tech, like one EMR to a different
Yeah.
EMR, and just even adjusting to a new physician or a new primary care provider, how do you prepare your patients to transition over to a new way of doing direct primary
Yeah.
care in terms of the tech and in terms of this is who is going to be taking care of you in the future?
You do it very carefully. I was listening to a podcast earlier today. This reminds me, like they were looking at death certificates from the 1800s, and like the reason for death on a good handful of them, or like the how did the person die section was filled out, and it said suddenly. Like,
Oh
oh,
my
that makes sense. So
gosh.
like, how do you transition your patient? Carefully. You do it carefully. It's like, did I do it right? I have no idea. I have stumbled through the last year of these poor patients being like, oh, Dr. Short's leaving to be with his kid. Like, oh, Lauren's leaving to go on a maternity leave, my nurse. And oh, Lauren has decided to stay home with her kid. And oh, I'm pregnant. I actually didn't tell my patients I was pregnant because I was so overwhelmed with everything that like the
Yeah.
last thing I wanted was for them to be like, and how are you? Because I was going to be like, not good. Please don't ask me that. But anyway, what we tried to do is we tried to be really explicit. And like anything in direct primary care, we really tried to put the relationship at the center of the transition, and just saying like, we are here for you. Like, there's no need to panic. You call my number, I'm still going to answer. You email me at my usual email addresses, I'm still going to respond. We changed addresses. It's updated on Google, on our website, on our footer. Like, I'm going to, you're going to hear very explicitly, we're at a new location, just like over sharing and
Mhm.
over communicating. At the same time, like we're also trying to not scare people, because when Dr. Short left, I sent out an email, and immediately people were like, well, I need to find a new physician, and they quit. And I was
Mhm.
like, well, that's interesting, because like with him leaving, regardless, you're gonna have to find a new physician. But if you stuck with us, you wouldn't have to find a new clinic also. So you don't need to leave, but people have their reasons. And I think sometimes it was a convenient excuse for them to move on. But I don't know, give people love. Just give them a little love, give them a little respect. They're gonna be scared. They're gonna reach out like with different emotions, but ultimately they're just scared that they're losing something. And you sort of have to TLC that a little bit.
Yeah, it's especially I can see that with the patients, especially in DPC, having a relationship with their doctor and not the typical like, oh, I haven't seen you in 3 years because
Right, right,
every
right,
time I wanted to come in, it wasn't your shift or,
right.
whatever the reason is. So I can definitely see that. Now, going off of that, if a person were looking to future proof their business, because that's a big question in entrepreneurship. When you talk about going from like the teen years of a business to really being in that place of my business is working, my model is working. How do I finesse that? How do I take it to the next level? Even if a person, at some point closes their business, how do you think about future proofing one's business so that it could potentially be ready to merge or to close or to expand? I think about that as a business
Oh,
owner
yeah.
in DPC, especially with this movement growing as it is.
Yeah. I mean, this kind of goes back to the DPC 101
Mhm.
concept. You're a business owner, and every business owner, from the very beginning, from the moment you open your doors, you need to think about what the end looks like. And that's not a negative thing. It could be because like what we're going through, you're merging with another clinic. It could be because you have to close.
Mhm.
It could be because you are brilliant and successful and you are selling to Google. I don't know who you're going to sell to. Walmart, who knows? It could be because, life transitions.
Mhm.
Kids come along and you need to do something different and you just want to close the doors. It could be because, God forbid, you die. Like, there are so many reasons why a business ends, and most DPCs are probably set up as LLCs, like sole proprietorships, and so it's very much on your shoulders as to where this business goes and how it succeeds, fails, etc. And so from the very beginning, you sort of have to build your business to think about, what sort of resiliency do I need to build? I always said this to my staff: if I get hit by a bus tomorrow, y'all need to know how to run this business without
Yeah.
me. And so that became the beginning of, we have a really, really big policies and procedures. I think it's like 90 pages last time I checked, which I know sounds probably small to some people. I don't know. But it literally has everything. It has our vendor, relations. It has our like macros. It has, weird contact information. It has like the state rules about, reporting. And we tried to make it a living document so
Mhm.
that if it was something really specific, we'd link out to a different document. So it's like, this is how we handle vaccines, and we have a vaccine policy. Like, this is how we handle controlled substances. We have a controlled substance policy, so that our P&P always links out to the more editable live document. So it never got stale.
Awesome.
And then there's a lot of SaaS, best in class software solutions that you can use to make sure that you retain control over like the communications of your business. So VoIP phones, for example, where you can port numbers and you can take that anywhere you need to go. You can port that into a different system, e-faxing, making sure that things can be forwarded. Obviously everybody's, hopefully, well, maybe not everybody, but electronic record storage, things like that. Like, I know this sounds kind of morbid, like you're going to close your business, but truly, like, if you think about a transition in a business, like, these are the little things you need to think about. Like, do you have control over your email address? Like, or, are your clinicians using all, different email addresses? Like, do you have, control over the information in there? Like, business is about control. But then but future proofing can also be a good thing, because you're like really, you're growing and really successful. And those things are still true, right? Like,
Mhm.
make sure your policies and procedures are clear. Make sure that people know where to find them. Maybe they don't have to have them memorized, but they need to know where to find them so that they can operate independently.
Yeah, I mean, we, especially in primary care, are always talking to our patients about, well, especially older patients or people who are ill, about, post forms, about, in my case, I use the 5 wishes packet, but
Yeah.
definitely I think that, thinking about the future, like we say to our patients when they're, well, and talking about these things, it's not the most comfortable conversation, but it's so important to preserve what you've built. And so, when we talk about culture, it's preserving your culture, it's preserving what, your patients are used to, whether that be it's still you in 10 years, or whether that be it looks different. And so this idea of future proofing, it's not just pertinent to DPC, it's pertinent to all businesses. So I really appreciate that.
Also, don't let all your employees get pregnant at the same time. No, I'm kidding. I'm kidding. That is 100% a joke. Like, that was a tough that was a tough go last year.
Oh my goodness. I cannot imagine. I cannot imagine. No, when you talked about, working on this higher level of how to make an impact in bigger societies nationally, hopefully, you work with Sesame. And so
Yeah.
I want to ask, how did you get into this role? And what advice do you have for those looking into potentially non-clinical roles, or consulting work?
Sure.
Because when people get that entrepreneur bug, it opens a lot of doors. And so I love that you have different pots on the stove.
Oh God, yeah.
And this is definitely one of them.
Yes, when I have been telling people who don't know me very well that I'm selling my clinic and moving away from patient care, they're like, "Oh, what are you gonna do?" And I'm like, "You have no idea how many jobs I currently have, and I am trying to get rid of one of my many jobs because I am overworked right now."
Yeah.
So I guess the short answer to your question is, just yell loudly and people will hear you and pay attention to you, and eventually they'll be like, "Oh, you seem interested in this, like, here, why don't you take this job?" And if you're just standing, you're like, "Oh yeah, sure, I'll take that job." But I think that being a DPC doc, to your point, you become entrepreneurial. You also become really independent, right? So like,
Mhm.
you're not beholden to any employer. or non-compete, or like your benefits aren't tied to somebody, or your malpractice. You also have a lot of flexibility as to what opportunities you can pursue, what risks you want to take. And so, and if you have an idea, pursue it. During COVID, one of my entrepreneurial friends who's not in healthcare, he's kind of in social justice, we had testing. He was like, we have a community need. We got together, pitched to a local nonprofit about providing testing for the community, and basically just created this hodgepodge of an effort. And I'm still the clinician on record for all of their vaccination and testing efforts here in the metro. And that just came out of like a spur of the moment, like, hey, this is a need that we've identified. I have the malpractice, I have the business, I have the vendor relationships. Like, all I need is a nonprofit partner, because obviously I don't want people donating to me in my clinic, but I don't want that financial obligation. Like, we needed a partner. And so that was it was seizing an opportunity and kind of creating one and going out there and finding it. As far as Sesame, it was a similar thing, networking, talking out loud, discussing with my DPC colleagues, like, what's going on out there, like just being out there and present, and then speaking up. Like, when I heard about the opportunity, I was like, I want to get involved in this. Like, how can I help? You got to be careful, because if you collect jobs like me, eventually you'll have too many jobs. But it's great. I still do locums too, like in the ER and the inpatient world, like, because I actually really like that realm, and it keeps me really sharp. And so I don't know. You just do what you want to do. It's fine, guys. Like, be explorers and be brave, and things will come your way.
And on that note, one of the big things that I keep seeing in the DPC Women's Facebook group is, how do you learn to value yourself, and how do you put a number on how much your time is worth?
It's a really important point to actually think about that, because our like per unit value, like, how much, dollars per hour, can kind of get lost in the DPC world, right? Because you can work 16-hour days in DPC, 5 days a week. You can work long days if you don't put some clear boundaries on what, again, going back to what I said earlier, like, what can you do to sustain a career? Because that's not going to work in the long run. And I think that goes to valuing yourself, kind of in air quotes, not in an explicit, like, I am worth X amount per hour, but rather like, I am worth taking time to spend with my family. And like, at 4:30 or at 5, when I say I'm done working, I'm literally done working. And if patients don't get responded to until the next day, guess what? That's the business I'm going to run. And that's how I'm going to value my time, because I value being with my family. I value being on with my family and not multitasking, and not, having the computer open over dinner and, responding to emails. Like, here's the deal. Half the time, people, if you don't respond right away, like, they're either going to figure it out on their own, or they're going to get better by tomorrow, or they're going to be fine getting your advice the next day. It's like, it's not actually going to matter if you respond, or do whatever in that moment. I was talking to Phil Eskew one time. It was fantastic. He was like, the more emails I respond to, the more emails I get. I was just like, oh, that's fantastic. So the answer is just like, write fewer emails and you get fewer emails. Yeah, that's it. Like, so essentially, like, sometimes we're the ones overworking ourselves, because we're being a little bit too responsive we're too giving, I think. And I mean that, like, kind of collectively, as like, I think family physicians give a lot without being explicitly compensated. But at a certain point, I'm happy to talk numbers with anybody who wants to talk numbers as to like what I actually think monetarily our time is worth. But it depends, and it kind of depends on, your level of expertise and what you're doing and who you're doing it for, and ultimately, like, how badly do you want to do it? Lower price that you might want to command, or like, how much do you not want to do it? Like, charge way more. There's always a number, and you can always come to a number. But I think we tend to undervalue ourselves as family physicians.
I definitely would agree with that. I mean, especially when we talk about consulting work, I frequently see people talking about MGMA data equals my worth in any realm of business. And that's definitely not the case. So I encourage people to reach out to you, to reach out to each other, to talk about, like, if you're doing consulting work, if you're working beyond your DPC, have that conversation about how much is my time worth, and experiment with it.
Oh, absolutely. I mean, in the worst, if your consulting fees are too high, somebody will say, no, I'm not going to pay them. But that's not the worst thing that they could say, right? It always kind of feels bad when you put out a price and people are like, oh yeah, absolutely. Like, dang it. Like, I could have asked for more. But I don't know. I think that the thing to hammer home is like, you're a professional and you spent a long time getting to where you are, and you have an immense amount of knowledge, not just from the medical side, to your point, but also, I mean, you're a DPC doctor, you're a business owner, you understand like the economics of healthcare, you understand, consumer demand, you understand a lot more than people are probably going to give you credit for right off the cuff, but it's worth quite a bit. And that's what people are paying you for when they're paying you for consulting, is that sort of like the secret sauce, right? That's not really quantifiable, but is so important to whatever they're trying to accomplish and whatever effort they're bringing you in for. And so don't devalue yourself, because you got secret sauce.
I love that. And in closing, I want to highlight an interview that you had done on the Fundamism podcast, because you spoke about, you got about 2 years out of residency, you got used to the idea of free time and self-care. And now that you have been a resident, you've been chief resident, you've opened your DPC, you've merged your DPC, you've had a baby, you've had people pregnant all at the same time in your clinic. I want to ask, what does self-care look like for you these days?
Oh, so this is very important. When I did that podcast interview, I was just far enough out of residency, that I was like just absolutely bamboozled by the idea of free time. I was like, this weekend, like, what am I doing? I have a free weekend. So like any pathological doctor, I definitely filled it up with all these jobs that I collected. And so, so self-care is like, I am working from home today, and I definitely took my child in to take care, because I know that to be a better mom, I need the time to get my work done and to process. And I went on a walk earlier this morning and got a coffee, and actually got on a group call with my mom and my sister, and we call it our weekly walk and talk, and just making sure that that happens and prioritizing it. And ultimately, this is going to sound like a cliche, but I guess it's a cliche because it's true and it gets said a lot. Say no. And that goes back to valuing your time, right? Like making sure that you are maximizing the hours, the economic impact of the hours that you are working, so that you can maximize that time to do the things that fill your cup. And that's not to say that, like, I think sitting with a patient and talking with a patient is actually a really fulfilling thing. Probably too much. So like, that's actually part of my problem, is that I really enjoy sitting and talking with people. So that at the end of the day, I'm like, oh crap, now I need to do my refills and my notes and everything like that. So I don't mean to say that like work equals bad. That's absolutely not it. But rather to like, to make sure you say no to the things that are not fulfilling, right? There was a really good exercise that I did with my women's entrepreneurship group, where you set a timer for 2 minutes, and without overthinking it, you just sort of like write down everything you do in a day, just whatever, everything. When the timer is off, put your pencil down, look over it, and on that list, see what you can either cross out or outsource that's not fulfilling. And like, what are the things that you're pressuring yourself to do for no good reason? Like be honest with yourself. Like, are you doing things out of guilt? Are you doing things because you feel like you should? Are you doing things out of pride? Who knows why you're doing them, but like ultimately they could, like get a frozen meal if cooking is something that's like really hard for you. There's nothing wrong with that. Nobody's going to give you a gold star for like making a meal if it's really exhausting for you. I know a lot of women I've spoken with have a hard time with some of the domestic duties, like in the household, like cleaning and stuff like that. Like, dude, there are people who will do that. Hire that out. And so, it's not something that you have to own or be proud about. If it's a commute, think about like, how do you change that? Do you redesign your practice so that you're doing maybe more telehealth, doing some days where you're at home so you don't have that commute? I think there are options. And so self-care is sometimes not about like adding like yoga, right? Like it's not necessarily about adding more. Sometimes it's about the minuses.
And definitely going back to valuing yourself and valuing your time. If you know that, you need something to happen, and like you have to hire someone to help clean your house, and your overhead for life goes up, then your pricing can also go up to adjust to that.
That's right. That's exactly right. Hashtag first world problems, right? But that's the truth. You sort of have to think about it globally. It's like, what is my time worth, literally? And if I can find somebody else to do this for less of a cost, then it is worth my time to pay them and then continue doing that thing that I do that generates more revenue.
Love it. Thank you so much, Dr. Edwards, for joining us today.
Thank you for having me. I absolutely enjoyed this conversation. Thank you so much.